Danielle, and welcome everybody. We are going to discuss the post-COVID-19 syndromes, which is a fairly rapidly developing topic. We're just about 1 year into the pandemic, and new information is coming to light every day. And so much of what I say now may be outmoded in 6 months. But we know a lot more now than we did a year ago. So to give you an overview of the scope of the post-COVID problem, the pandemic is affecting millions of people throughout the country and throughout the world. During, and it will continue even after the pandemic is over, many patients and frontline workers who recover from COVID have persistent symptoms and disabilities. The most severely affected actually have permanent disabilities or may have permanent disabilities. We don't actually know that. It's only about a year. Many people without COVID are also experiencing symptoms due to the impact of the pandemic, and we'll talk about that as well. So this is just to remind you that the number of cases has grown exponentially from the beginning. In the United States, there have been over 31 million cases, worldwide over 140 million cases. This slide is up through April 15th, and it shows that we are starting to see a little bit of downturn in the rate of acceleration, but we're continuing to see many new cases daily. So our goals and objectives in this talk are to provide an overview of the type of late consequences or sequela seen following COVID-19 infection, with a special focus on respiratory or sleep problems. I come to this from three different perspectives. I'm a pulmonary specialist, and so I see people who have respiratory problems. I'm also a sleep specialist. I'm the director of the sleep center, and I'm seeing people with sleep problems. And I'm the director of the pulmonary rehab program, and we're seeing patients who are undergoing pulmonary rehabilitation who've had COVID. Our second objective is to discuss options for treatment and rehabilitation. And thirdly, to discuss the effects of the pandemic and its response on the general population, particularly on sleep. So this is a list of the most common symptoms of acute COVID. During the acute phase of the infection, the most frequent things that patients experience are fever, cough, fatigue, difficulty breathing, very commonly a loss of sense of smell, difficulty sleeping, and a variety of other symptoms during the acute phase that are a little less common. There are also many complications that occur during the acute phase. Most frequently, people develop pneumonia or more seriously, respiratory failure. There can be cardiac problems. Blood clots can occur in the arteries, veins, or lungs. Some patients develop other complications like stroke, kidney failure. And one of the complications that I listed is the development subsequently of what's now called the post-acute sequela of SARS or PASC. So a couple general comments about the delayed or prolonged symptoms of post-COVID. One is that they are uncommon after mild or asymptomatic disease. The exception for that is chronic fatigue does seem to occur even with mild cases, not so much asymptomatic cases, but these sequelae are overall uncommon in mild cases. They are more common after people have been hospitalized who have somewhat more severe cases of COVID, and they're very common in people who've had critical illness or been in intensive care for COVID-related problems. So there are a number of studies. I'm going to show you data which were taken at different time points. And initially, all the data I'm going to show you are from people who've been hospitalized and the follow-up afterwards. Towards the end, we'll include people who had milder cases who were not hospitalized. But all the initial data came from people who were sick enough to be hospitalized and were followed subsequently. So in this relatively early study from last year, they looked at 1,600 American hospitalized patients, and a third of them had persistent symptoms. And this is at the 60-day mark. This is at 2 months after. And 1 out of 5, about 20%, reported new or worsening symptoms. The most common symptoms are shortness of breath, either with exertion, with stair climbing, or even at rest, cough, and loss of sense of smell or taste. Another study at 6 months showed that 3/4 of hospitalized patients still have at least one symptom after 6 months from hospitalization, but that people with severe COVID were 2.5 times more likely to have residual symptoms than those who had milder illness. The most frequent symptoms at 6 months: fatigue or muscle weakness, difficulty sleeping, anxiety or depression, hair loss, and disordered smell. Of the most severely ill patients, over half had abnormal lung function, and over half had abnormal images of their lungs on CAT scan. So these are the most common post-COVID-19 sequelae following hospitalization. And we're going to talk a little bit about each of these briefly. So respiratory symptoms and limitations, uh, mental or what we call cognitive function impairment, physical deconditioning, something called CRIMYNE, which is an acronym for critical illness-related myopathy and neuropathy, weakening of the heart muscle, the medical term is cardiomyopathy, fatigue, something called POTS syndrome, which we'll explain shortly, difficulty swallowing, joint stiffness and pain, psychiatric problems, difficulty sleeping, and an anosmia, which is loss of sense of smell. Some other nonspecific symptoms: brain fog, headache, dizziness with standing, palpitations, and chest pain. So we're going to run through briefly most of those. So respiratory problems. So the most frequently, it's people who are having persistent shortness of breath, either at rest or with exertion. Some people have low oxygen levels, needing oxygen. Abnormal breathing tests, what we call pulmonary function or lung function tests, or abnormalities on the chest x-ray or CAT scan. And I'm going to show you what those look like so you'll have a sense of what the kinds of things that we're seeing. So what we see are what we call lung infiltrates, and they're these hazy looking areas that you see around the edges of the lung. You can see the pink arrow. I don't know if you can see where I'm circling, and you can see it on the one on the right. Again, there's a pink arrow pointing to it, but these are hazy densities we call infiltrates that we believe reflect inflammation from the virus. And they're described as ground glass infiltrates because they resemble the appearance of ground glass. They may persist long after people feel better, after their acute symptoms have resolved. They've been seen on patients' CAT scans over 6 months after people have left the hospital. Now, those infiltrates can progress. This is someone who's in the hospital. You can see that those ground glass areas are encompassing most of the lung in these. And this is somebody who's developing respiratory failure, what we call adult respiratory distress syndrome, ARDS. And this is the leading reason why people with COVID wind up on respirators. Another pattern that we see is called atelectasis, which means a collapse of a part of the lung. On an x-ray, it might look like a straight line. On a CAT scan, a wedgy-looking area, which represents a part of the lung that no longer has air, that's collapsed. And lastly, in a later stage, what we will sometimes see are areas of lung scarring, what we call fibrosis. These areas that have these cyst-like areas in them, but they represent areas of the lung that have scarred and are no longer functioning. So the persistence of pulmonary problems has been tracked. This is a study that was done in Munster, Austria, over a 3-month period in the spring of last year. And at 6 weeks after discharge, almost 2/3 of the patients who had been hospitalized had shortness of breath or cough. Most of them had infiltrates on CAT scan, 88%, and lung function was reduced in about a third. The same patients followed up to 12 weeks. The numbers had come down some, but still over half had shortness of breath or cough. Infiltrates on CAT scan present in a little over half. That had come down from 88% to 56%. Reduced lung function went from about 1 out of 3 to 1 out of 5. And you could see a depiction of these infiltrates here. They're just labeled in red so that they're highlighted. In a larger study that was done out of England, of almost 50,000 patients, 30% of the people discharged from the hospital with COVID still had a respiratory diagnosis. So they still had infiltrates or cough or shortness of breath. And 40% of these people had no prior respiratory history. The second common symptom that we see late is fatigue or weakness. In most surveys, is the most common symptom. And in this particular study, at 6 months, 63% of COVID patients still reported fatigue or muscle weakness. The study was performed in England, but it was studying patients who are actually in the Wuhan province. Joint stiffness is particularly common in older patients who've been bedridden. Chest pain or chest discomfort is present in a fair number of patients, and difficulty swallowing, particularly in patients who've been in ICUs, non-respirators. Physical deconditioning. Now, that's a medical term that basically is equivalent to the term being out of shape. And what occurs with physical deconditioning is a reduction in exercise capacity, which is without or way beyond any impairment in lung function. There often is weakness, which may be with reduced muscle mass. And what often happens is people have inappropriately rapid heart rate or breathing for the level of exercise. So just a little bit of walking, and it's as if they were running real fast, even if they have, or especially when they have normal lung or heart function. CRIMYNE stands for two conditions that often occur together: myopathy, which is severe muscle wasting or atrophy, or peripheral neuropathy, which is a malfunction of the nerves of the limbs, where there's tingling or numbness or pain and weakness. This is particularly common in COVID patients who've been on respirators or in intensive care. And this condition has been, it's not new to COVID. This was recognized for a long time in patients who have respiratory failure and critical illness for any number of reasons. Now, POTS syndrome, I mentioned before, that's an acronym that stands for Postural Orthostatic Tachycardia syndrome. And basically what that is a condition where people have rapid heart rate as soon as they stand up. So they go from laying or sitting to standing, and their heart rate jumps by 30 beats a minute. They'll often feel lightheaded. They may describe it as brain fog or severe fatigue or getting palpitations as soon as they stand or walk. They're not able to tolerate exercise or activity or even standing up often because their heart rate jumps up so quickly. And what it has to do with in POTS syndrome is not a heart problem primarily. What it is a malfunction of the nervous system, the part of the nervous system we call the autonomic nervous system that unconsciously and automatically controls bodily functions like blood pressure and heart rate. This has been identified in viruses before. It does seem to be particularly common or more common in patients with COVID than it has been with other viruses. Fortunately, there is treatment. Patients are often treated with giving them fluid or salt. venous compression stockings to return blood flow. There are medications that are effective, and physical therapy has been shown to be effective. A program was developed of 3 months of rehab with graded exercise, starting exercising while someone's laying down and graduating them to sitting and then eventually standing. And simultaneous to that, giving them salt and water. This has been termed the Levine protocol for one of the doctors that developed this a number of years ago. Cardiomyopathy after COVID, we don't really know how frequent it is. We do know that echocardiograms taken in patients who were discharged from the hospital after 6 weeks, that the majority do so show some signs of abnormal heart function. And MRIs performed as much as 3 months after people were discharged from the hospital, 60% of them show inflammation of the heart muscle, what's called myocarditis. Not all these people are symptomatic, but some are. We're not really sure how significant that is without longer term follow-up. Uh, it's been recognized for almost since the beginning of the pandemic that most patients who have acute COVID lose their sense of smell. It's over 80%. The virus appears to attack the cells in the nose, may actually even reach the centers of the brain that regulate the sense of smell. When there's a complete loss of smell, we call it anosmia, no smell. A lot of people don't lose it completely. They have partial loss of smell, and that's called hyposmia, or they have a distorted sense of smell. And a few people get olfactory hallucinations. They smell things that are not there. That's called phantasmia. It's a phantom smell. And most often, what they complain about is they smell something burning when there really isn't anything. Some people also lose their sense of taste. That's called agesia. Um, and with the loss of smell and or taste, there often is a secondary loss of appetite. Food doesn't taste as good. Everything tastes bland. A lot of people will lose weight, and some people even get depressed related to this. There is a potential danger with this because people who lose their sense of smell don't smell smoke if there's fire or gas leak, and so they need to have working detectors if for smoke and gas, especially if they live alone. The good news about anosmia is that the majority of them resolve in about a month, but there are patients in whom it persists for 6 months or longer. Um, Men or those who only have partial loss do recover faster than those with total loss or in women. Um, a program has been developed to accelerate the improvement. The sense of smell may return with some training of the called smell training or olfactory training, and it's relatively simple. The program involves setting up 4 different odors in different categories, typically a floral like roses, citrus like lemon, spice like clove, and eucalyptics, and then smelling these 4 odors twice a day for about 15 seconds each, and just using the same exact ones, the same exact routine. There is a self-training on YouTube called olfactory training that people can watch and see how that's done. But that does seem to train the cells in the nose to smell again faster than would be recovered otherwise. Psychiatric sequela. Um, so we see a variety of psychiatric problems in people who've had COVID. Again, these are hospitalized patients, post-traumatic stress disorder, depression, those are about 30%, anxiety and difficulty sleeping in about 40%, and even obsessive compulsive symptoms in about 1 out of 5. So post-traumatic stress disorder has been recognized for a while in people who are critically ill or very ill. It does occur in patients who've had significant cases of COVID. And there are 4 aspects to this: behavioral changes. So people are hypervigilant, they're jumpy and irritable. They may show agitation or even hostility. That's very inappropriate. And they often become isolated. Psychological problems include anxiety, fear, and mistrust, and flashbacks, where they'll feel like they're reliving their experience in the ICU. There's often depression manifested by a loss of pleasure or interest in activities, a lot of detachment and loneliness, and then sleep problems, most typically insomnia, but also there may be nightmares or even nocturnal panic, waking up with rapid heart rate and sweating and a panicked feeling. There are some neurologic and cognitive or mental sequelae of COVID. People have been reporting difficulty with thinking and reasoning, problems with memory and concentration, executive function impairment, meaning difficulty with analysis and decision making. And then those people who have had stroke will have stroke deficits, loss or weakness of arms or legs. Persistent sleep difficulties has been reported in about a quarter of patients who've had hospitalization with COVID. Now, during COVID, during the acute phase, 3/4 of people have difficulty sleeping. The most common symptom after 6 months affecting sleep are difficulty falling asleep, or trouble maintaining sleep. In other words, you fall asleep but then wake up shortly later repeatedly. And again, nightmares or flashbacks may be present even without the full-blown post-traumatic stress disorder. So you may have heard some press recently about a unofficially named sleep disorder called Coronasomnia or COVID-somnia, and that is a marked increase in disturbed sleep or difficulty sleeping. And it may be due to lingering symptoms in COVID survivors like cough or breathing trouble that's keeping people awake. It may be related to PTSD in COVID survivors or frontline workers. And it's even seen in non-COVID patients who are worried about getting sick and develop insomnia or nightmares. And I'm going to return to this at the end when I talk about coronasomnia in people who haven't had COVID. But for now, we're putting it in the context of the post-COVID syndromes. And of course, people may have a combination of several of these late symptoms, leading to what's called a limitation of ADL, activities of daily living, like housework or walking or doing chores. 40% of people hospitalized with COVID report that at 2 months, they're unable to return to their normal level of activity. Frequently, there's exertional shortness of breath or palpitations, and this may be multifactorial. They may have cardiomyopathy, they may have POTS, they may have deconditioning altogether, and then very commonly generalized weakness and fatigue. So let's talk about fatigue, because this is one of the most frequent late symptoms of COVID. There were 2 early studies, one from Ireland, one from Italy, both having similar results. Over 50% of patients at 9 to 10 weeks after the onset of their illness had persistent fatigue. And in 41% of them, they reported that a significant worsening of their quality of life. Interestingly, in all of these studies, there have been no association of the fatigue with the severity of the acute illness. So these are people who were hospitalized or not, or with the level of inflammation. Now, important distinction needs to be made that is between fatigue and sleepiness. The term fatigue can be somewhat ambiguous, but when we are trying to be precise, what we mean by fatigue is a lack of physical, or in some cases mental energy, or the perception of weakness or poor endurance. We're not talking about sleepiness. Sleepiness is different. Sleepiness is the inability to stay awake, inability to maintain wakefulness or alertness, or unintentional sleep onset when it's not appropriate. So fatigue we see with anemia or neurologic disorders, with chronic fatigue syndrome, depression, or just with overexertion physically. Sleepiness we see with sleep disorders, sleep apnea, narcolepsy, or not getting enough sleep or fragmented sleep. Now, in some cases, we see the two together. Sleepiness and fatigue together are seen most often in acute infections, in people who are having fever, or people who just have difficulty separating the two, and they'll just conflate the two as really one. But we try to make a distinction because the causes are often different. Now, a term's been introduced recently called the post-acute sequela of SARS-CoV-2, or PASC, and this is referring to symptoms, particularly fatigue, that persist over 4 weeks. And it's been given a lot of other terms in the media and the lay population. These are the COVID long haulers, or long COVID, long haul COVID, post-COVID, post-acute COVID, and so forth. But the official term that's been coined now is PASC, post-acute sequela of SARS. And to a large degree, it's chronic fatigue. Its cause is really unknown. There may be several different variants or different causes. So some of the possibilities include a post-viral chronic fatigue syndrome, just like the other, the well-known chronic fatigue, which, by the way, has the medical term myalgia encephalomyelitis. Chronic fatigue may be due to POTS syndrome with rapid heart rates when standing. It may be due to physical deconditioning, or may be due to post-traumatic stress or depression. It does not appear to be due to persistent infection. Almost always, with very few exceptions, do these people continue to test positive for the virus. This condition is not associated with the severity of the COVID illness, whether people were hospitalized or needed oxygen, or markers of ongoing inflammation. It is more common, initially reported in women and those who already have some anxiety and depression. Now, a leading physician in England for the chronic fatigue syndrome or myalgic encephalomyelitis has stated that he feels that it's quite likely that some people with COVID will develop the chronic fatigue syndrome, virtually indistinguishable from the one that's been recognized in the past. So some risk factors, it's largely unknown who's at risk for developing this. It seems to be more common in people over 50, although it can be seen in younger people. And it is seen more often in people with 2 or more pre-existing chronic illnesses. A lot of speculation about what causes this. And these are the leading theories. There may be some ongoing low-level inflammation in the brain, heart, or lungs. Again, as I said, the inflammatory markers don't seem to correlate with it. There may be some autoimmune condition in some people with antibodies against people's own cells. There may be some reduction in blood flow to the brain. There may be some impairment in mitochondrial function. These are the energy-producing organs in cells, or decreased production of energy molecules like glucose or ATP. There may be a weakening of the immune system. There may be blood clots in the tiny capillaries in the heart. And as I said, it's not due to persistent infection. There is ongoing research about this. The Congress appropriated $1.15 billion to the NIH to research the prolonged health consequences of SARS-CoV infection. There is an ongoing survey that anybody can participate with using a smartphone app called the COVID Symptom Study by a company called Zoe Global Limited. You can access it on a computer also, covid.joinzoe.com. And they've collected data from over 4 million app users. And what's particularly interesting and useful about their data is anybody can log on. And many people who've developed COVID and been through all of this started reporting before they even had the onset of COVID symptoms, some before they even got sick. And so they've selected out a subgroup of those people who started very early tracking and then developed COVID and have responded. So this has really been a great source of information about people who have COVID who have not been hospitalized or really significantly been in the medical system. So information from that COVID-19 symptom study, and a lot of this is preliminary, they've collected data from 4.65 million app users. These are self-reported symptoms, and it does include non-hospitalized and therefore milder cases. And what their data is showing so far is 1 in 20 with COVID-19 have continued symptoms over 8 weeks, and 1 in 50 COVID-19 suffer symptoms over 12 weeks. So here we're talking about, 1 in 20 is 2%, 1 in 50, 1 in 20, that's 5%, 1 in 50 is 2%. These numbers are a lot lower than the ones I showed you before, but those were of hospitalized patients. This is all patients now with COVID. And the important thing to remember, and if you recall the first slide that I showed, or one of the first slides, was, how many millions of people have COVID. So even if we're talking about something that affects 2 or 5% of the of people who've had COVID, if we're talking about something, a condition that affects 30 or 50 million people, or worldwide 150 million people, we're still talking about a very large number of people who have post-COVID syndrome. What their data preliminary is showing about post-COVID-19 is that it's most likely to develop in people over 50, more likely in women, more likely in people who've had 5 or more symptoms, including fatigue, headache, shortness of breath, and loss of sense of smell, and more common in people who have pre-existing asthma. No other pre-existing medical condition has thus far been associated with the development of post-COVID-19 symptoms. Just a word about the chronic fatigue that pre-exists COVID, and a lot of patients who suffer from this have benefited from lifestyle changes, and they're summarized as the 4 Ps. Planning out one's activities carefully, to use the activities that require the most energy early in the day before the fatigue worsens. Pacing out activities over the course of the day or over the course of the week. Prioritizing doing the things that require to be done the earliest when you're able to do them. And positioning, meaning keeping things close that need to be close at hand, not having to reach up on high shelves when something's needed frequently. So just some common sense things that help with making the lifestyle more friendly. Now, if somebody's had COVID and they're concerned because they may be still having symptoms, they should have medical evaluation. And this is sort of just a rough suggestion about the type of medical evaluation that people who've had COVID would go through. It's generally recommended to have an evaluation 3 or 4 weeks after the acute illness, particularly people who were very ill. Repeat COVID testing, generally not necessary or helpful once somebody's symptoms have recovered. It's usually negative, but it's not of much significance what the COVID test is going to show a long time after the acute illness has resolved. Important to check somebody's oxygen level to see if they need oxygen, blood pressure and pulse, both sitting and standing, to see if they develop that symptoms of POTS syndrome, the tachycardia with standing. If there's a history of pneumonia with COVID or difficulty breathing, they should have a chest x-ray checked after about 12 weeks. If there's persistent shortness of breath or low oxygen levels, they should have a CAT scan, which is much more sensitive at picking up abnormalities than a chest x-ray. Breathing test, especially people who have persistent or new onset of trouble breathing. Cardiac evaluation, including EKG and an echocardiogram if there were signs of myocarditis or injury to the heart. A test called a tilt table test is the most sensitive test for POTS syndrome. It's laying on a table that's gradually raised up vertically and monitoring the heart rate and the blood pressure. Now, we'll turn to talk about treatment for post-COVID syndromes. And first of all, patients who have specific medical complications need to be evaluated, diagnosed, and treated for those. Following that, though, a lot of people have persistent symptoms for which there's no additional treatment other than waiting. A lot of people do get better over time. But for people who have persistent symptoms, we have 2 different approaches. If they have persistent pulmonary problems, pulmonary rehabilitation. And if they have non-pulmonary problems or generalized weakness, general physical therapy and rehabilitation. So early on, it was recognized that there isn't any data about about rehabilitation, and so a task force was assembled with an international group of over 90 experts, and they evaluated the situation. And they realized, number one, there's little data about safety or effectiveness or even methods to do rehabilitation for COVID patients, but there's a massive need for rehab that couldn't really wait for years to have randomized controlled studies done and analyzed and published. And that's how long these things take. So a consensus group was assembled of 93 experts in pulmonary rehab, respiratory medicine, and rehabilitation medicine from around the world. They had a virtual meeting in the spring of 2020, and they came to some recommendations based on indirect evidence and on their clinical experience. Well, what's their clinical experience based on? They based it on, among other things, these things. There's a known post-intensive care syndrome called PICS, with impairments, both physical, cognitive, and psychiatric, and a lot of experience with that over years. And to some extent, post-COVID syndromes overlap with that. There's experience dealing with POT syndrome, with post-viral syndromes, such as following influenza or mononucleosis, and with the chronic fatigue syndrome, also known as myalgic encephalomyelitis. So they gathered all of that experience, and they came up with some guidelines and distilled about 20 or so guidelines to these 5 recommendations. One is that people hospitalized with COVID should be encouraged to do regular activities for 6 to 8 weeks after hospital discharge, and low to moderate intensity physical exercise at home on their own. Number 2, patients hospitalized with COVID should have evaluation for their lung function and their exercise capacity 6 to 8 weeks after leaving the hospital. One reason for delay is obviously so they're not contagious, and the other is because a lot of people spontaneously improve. Third is that COVID survivors who have impairment in lung function at 6 to 8 weeks should receive pulmonary rehabilitation. And COVID survivors with generalized weakness at 6 to 8 weeks should receive a muscle strengthening program and nutritional support, physical therapy, general rehab. And lastly, COVID-19 survivors with psychological or emotional distress at 6 to 8 weeks should have a formal psychological assessment and treatment. So this is the one and only published data which came out of China about pulmonary rehab in COVID patients. They did a program of 2 sessions a week for 6 weeks with respiratory muscle training using a handheld device that I'll show you in a second. Coughing exercises, diaphragm training, where people would lay down and have a weight on their diaphragm and they would contract it, and stretching exercises focused on stretching the respiratory muscles. So this is the Inspiratory muscle trainer that they use. It's been around for a while, and it basically has some resistance. And when you inhale against it, you're lifting a weight with your diaphragm, essentially. So they published their results. They published data from 72 patients, all over 65, and they showed that they had improvement in their lung capacity and their pulmonary function measurements. Improved exercise capacity. They could do more exercise. They could do 25 minutes on a treadmill when they started only could do 5, for example. They had improvements in their quality of life. And most importantly, these improvements after they did rehab were greater than those of controls who were similar patients who did not do the rehab. So it wasn't simply a matter of passage of time. It was the intervention of doing the rehab. That is the one and only published study so far. There'll be more coming out in coming months and years. So we have developed at Valley Hospital a rehab program for post-COVID. And these are our criteria for who would be eligible. The first is that someone has documented COVID infection by a swab or antibody test, or very strong clinical suspicion if the opportunity for testing is passed. That they be at least 30 days or more after their fever and acute symptoms subsided. But that their pulmonary symptoms persist with difficulty breathing at rest or with exertion or cough, and they have some type of objective evidence for pulmonary limitation or abnormality, either an abnormal chest X-ray or CAT scan, abnormal breathing tests, or reduced oxygen levels. So what does a pulmonary rehab program consist of? Well, first, an initial evaluation, which includes evaluation of respiratory function, neurologic, psychiatric, and sleep screening. The rehabilitation involves breathing exercises, stretching, and light muscle strengthening. There's a focus on respiratory muscle training and graded reconditioning exercise, the most important part, which is aerobic training, starting low and gradually increasing. We call it progressive incremental reconditioning exercise, and all of this with some education and counseling. So there are some concerns and issues about rehab in the COVID era. There's obviously a risk of transmitting the virus to the staff or to other patients. So that's why there's a need for protective equipment and procedures. We want to ensure that patients are not infectious before coming to the program, which is one of the reasons for delaying rehab for 6 to 8 weeks. It is difficult for people to wear a mask while they're doing physical exercise. Anybody who's tried it knows what that feels like. So we allow people to take the mask off during, but to keep their mask on in between exercises, and to space patients who are doing exercise. And the staff, of course, can wear protective equipment while they're attending to people who are doing exercise. Insurance coverage is generally available if there is reduced lung capacity or imaging abnormalities. Insurance generally covered that before COVID and continues to do so now. And if somebody has disabilities but they don't meet criteria for pulmonary rehab, they very well might have coverage for general physical therapy and rehab. So to outline sort of the approach, if someone has pulmonary limitation, pulmonary rehab, but if they have symptoms of physical deconditioning, they're candidates for physical medicine and general rehab. If they have symptoms of neuropathy, either leg or arm weakness or leg or arm pain or tingling, if they haven't already had a neurologic evaluation, they should have that, and general physical medicine and rehab. And if they have sleep disturbances, insomnia, or excessive sleepiness, they should have a sleep evaluation. So finally, I'll spend a few minutes talking about coronasomnia that I mentioned earlier. And what's been identified is a marked increase in sleep problems during the pandemic, and it's been termed a tandemic. So it's another epidemic that's in tandem with the COVID-19 pandemic. And so it can be due to lingering symptoms in COVID survivors or in or post-traumatic stress in survivors or frontline workers. But a lot of it is people worried about getting sick, a disruption of people's normal routines, people spending more time in bed with a result of reduced sleep quality, social isolation, working from home, and people having reduced exercise and sunlight exposure. There are three groups. So first is people who've had COVID, who have persistent symptoms. They may have insomnia, and some people have increased sleepiness, what we call hypersomnia. There is a reportedly increased nightmares, and it is believed that the virus may affect the areas of the brain that control sleep and wakefulness. Second group are healthcare workers, and 36% of those have been reported or self-report that they are having sleeping difficulties. And the general population, 32% in surveys, are having sleep issues related to the virus. So let's just talk briefly about sleep and infections in general. Sleep is altered by infection. That's been known for a long time, and the immune response to infection is disrupted. There may be an increase in the duration of sleep. The immune system is affected by sleep. Prolonged sleep loss does weaken the body's immune system and makes it more prone to infection. We know that vaccines for influenza and hepatitis aren't as effective in people who are getting less than a normal amount of sleep. And it's been known for a long time infections make people feel tired and increases the desire for sleep. So the typical symptoms of coronasomnia are insomnia, difficulty either falling asleep or staying asleep, an increase in anxiety, depression, and feelings of stress, a delay in people's sleep schedules, going to bed later, getting up later, and getting less than the usual amount of sleep, the sleep deprivation, which can lead to sleepiness in the daytime and problems with concentration, memory, and mood. So surveys have shown that insomnia increased by 37% in the population during the pandemic. Difficulty falling asleep increased from 15% before the pandemic to 42%. Difficulty staying asleep increased from 24 to 40%. Anxiety increased threefold and depression fourfold. So we are seeing some ramifications deep into the general population. These are people who have not had COVID. What are some risk factors for coronasomnia? Well, the first obviously is people recovering from COVID, frontline workers and essential workers, unpaid caregivers. Women are more prone to develop it, young adults, and people of color. It's clear that stress leads to coronasomnia. One of the researchers in this field came up with the acronym of FED UP: financial stress, emotional stress, distance from others, unpredictability, and professional concerns. People concerned about their jobs. They're fed up. Stress is known to increase cortisol, which inhibits sleep. And there's an inverse relationship. When cortisol goes up, melatonin goes down, which further reduces sleep. Stress also reduces deeper sleep, what's called slow wave sleep, which is the most restorative stage of sleep, and increases the time that one is awake during the night or awakenings during the night. Additional causes of coronasomnia: loss of the daily routine. People's habitual sleep schedule is disrupted. Their circadian rhythm may be disrupted, not just by their sleep habits and scheduling, but by loss of other time markers during the day. What time are meals, and what time do they make the train, and so forth. These are all going to disrupt, when they're altered by a change in work pattern, are going to disrupt the circadian rhythm, which in turn will disrupt the sleep rhythm. What's most commonly observed is people who are not commuting and are working from home have later bedtime and later wake up time, what's called a phase delay. And if somebody does that for a while and then they try to go to sleep earlier, they're not going to be able to fall asleep. Working at home also reduces natural light exposure during the daytime, and natural light exposure is a factor that helps regulate the sleep-wake cycle and helps people to sleep at night. Similarly, lack of exercise. If you work from home, you're less likely to get out of the house to either exercise or just to walk to work or walk to your commute. And finally, an increase in media consumption. There's much more information about COVID on television, on computers, that increases people's fear and anxiety, and also increase their light exposure at night, especially blue light, but any light inhibits sleep. So finally, I'm going to conclude by reminding people of what are considered to be good sleep habits that would improve people's sleep during this pandemic. The first is to maintain a regular sleep-wake schedule, 7 days a week. Allow 7 to 9 hours of sleep every day. Avoid light and other electronic devices within 30 to 60 minutes of bedtime, which will inhibit sleep onset. That includes TV, computers, smartphones, tablets. Limit news watching in the evening hours. Keeping the bedroom dark, quiet, and cool. Getting adequate sunlight exposure during the day, especially in the morning hours or early afternoon. Avoiding late or long naps. If somebody needs to nap, keep it to 20 to 30 minutes and well before the evening hours. Avoiding alcohol within 3 to 4 hours of bedtime. Alcohol has a paradoxical effect. When it wears off, it causes awakenings. Avoiding caffeine within 6 to 8 hours of bedtime. Some people, the caffeine remains in their system for a long period of time and can keep people awake. Exercise is very good for sleep, just not within an hour of bedtime. Avoiding over-the-counter sleep aids that can be habit-forming, that promote light, not deep sleep, and can cause daytime drowsiness. And finally, avoiding late dinners, which tend to push the circadian rhythm, your biological clock, later and tend to make people fall asleep later. And with that, I will conclude and give you an opportunity for any questions.
Thank you, Dr. Barasch. Okay, so thank you everybody who wrote in a few comments of personal experiences that Dr. Barasch mentioned. One question that came in: when checking oxygen levels at home with oximeter, what is a normal range and what level is it to be concerned with, and when to call your doctor?
That's a very good question. So a normal range is above 95 to 99%. Doesn't need to be 99, but 94 is already slightly reduced. And there needs to, if it's consistently 94 or it drops to 94 or less, it means there is some type of problem, usually something with the lungs. We get particularly concerned when it reaches 90 or less. That's a situation where people need oxygen. But more importantly, once it falls below the normal range, it needs to be evaluated. It might be related to COVID or it might be a different issue. There's lots of things that could lead to low oxygen levels. The only other consideration is, to be sure about the accuracy of it. They've gotten a lot better, but the home oximeters used to be not that accurate. But it needs to be verified against a high quality oximeter. But yeah, definitely somebody should be evaluated if that falls below the normal range.
Great. Another question: my husband has sleep apnea. What is the number for oxygen range for him?
It's the same as for anybody else, right? Needs to be in the normal range. If somebody has sleep apnea and they're not treated, it will drop, because when you have an apnea, you're not breathing, you're not getting oxygen, and we'll often see people drop into the 80s or 70s. That's not a situation we want to tolerate. So when people are treated for sleep apnea, for example, with CPAP, the oxygen levels should stay in the normal range. Now, a common thing that people with sleep apnea do is they check their data from the machine. That's called the compliance data. It's recorded and it's often displayed. That gives an indication of whether there are apneas or not. That gives no indication about the oxygen levels. We have had situations where people had normal levels on the compliance chip. It's indicated no or very few apneas, but their oxygen levels were actually very low. And in that sense, that data can be a little bit misleading.
Interesting. Okay. So, how can we get an appointment with Dr. Barasch? You can actually go to valleyhealth.com valleyhealth.com, find a physician, and you can type his name in and his information will pop right up and you can call that phone number. Another question: how do these symptoms compare to those of the flu?
Well, it depends on which symptoms you're talking about. During the acute phase of COVID, they can overlap quite a bit with flu. People with the flu also get fever and chills and body aches, so there's a lot of overlap. And then there's the things that are somewhat more unique to COVID, the loss of sense of smell, for example. But the illness with COVID can get a lot more severe than we see with flu. It's a little bit more like the flu pandemic that occurred at the beginning of the 20th century in terms of severity, the frequency that people have respiratory failure and shock. Now, those things can occur with the flu. They're just very uncommon. But they're much more common in people with COVID. So there's some similarity in the acute symptoms. Now, the chronic symptoms, that's a different story. Far fewer people with influenza develop all of these post-viral sequelae. A few do, but the frequency and the variety that occur with COVID is much more than with influenza.
I think we have time for one more question. Are we seeing any similar long-term effects compared to what happened with SARS a few years back?
We're seeing much more with COVID than we were seeing with SARS. Now, don't forget, SARS was a very similar virus. The name is almost identical. This is, number 2. That was number 1. But there were not that many cases, so that the numbers that we're seeing, because we're seeing, in excess of 30 million Americans, by the time it's over, that may reach 40 million. We're seeing far more frequent sequelae, but it does seem to be amongst COVID patients that we're seeing it more frequently. I don't think a head-to-head analysis has been done precisely, but it was few and far between that we saw post-sequela from the previous SARS.
All right, well, thank you so much, Dr. Barasch. This was a very informative program. At this time, I'd like to just remember